Hi, this is Johanna Gader. I'm the Senior Health Informatics Advisor for the Department of Health and Human Services, Office of the Assistant Secretary of Health, and the Office of Population Affairs, where we manage the Title X Family Planning Program. I'm going to talk about the Family Planning Profile and what it can do for you and why you might want to take a look at it. So, the problem. What is our basic problem? Basically, at the current time, we operate a network of clinical sites that has over 4,000 clinical settings. There's in all U.S. states and territories. And we currently collect data in an aggregate format. So at the end of the year, we receive some information from all of our clinical sites that they did such and such number of tests against, so many different patients. It's only at a very high level. We can only get down to about the state or grantee level. And it takes about 23 months from the time of the window of when we first would see a patient in this network until we get a final report that we turn into a PDF that we can put onto our website. So it's not really particularly helpful for clinicians. And along with some advice from our clinical advisors and experts in our administrative side, we've been working towards what we would hope to be an encounter-level data submission. So we have about 7 million patient visits a year, and we'd like to get information about every single one of those patient visits. And this would give us the ability to calculate clinically relevant performance measures at greater granularity and provide that back to clinicians in more real time so that they can actually do something with that information. Part of the problem also includes that these clinical sites have a lot of demands placed upon their time as well as their vendors, right? There's a lot of funders that have different requirements in these clinical sites. There's a lot of quality and performance requirements from different programs, and in addition to organizational and jurisdictional quality and performance issues going up their chains. And then there's a range of public health reporting issues associated with adverse events, immunizations, and other kind of things. So these are the vendors and the clinicians and the administrative staff are pressed on all sides to enter data once and then probably again and again and again for right now, because all these systems tend to be siloed and different from each other. And we'd like to try and make it a little bit easier so that they can enter data once and reuse it later for many of these purposes. We did a survey in 2015 of our clinical sites. We had about 1,700 responses. And so far, it looks like there's still a lot of paper-based data exchange, even amongst those who use an EHR system. And then ultimately, it looks like only about a third of those EHR system users have a system that actually has structured data elements that are extractable for things like vital signs, like blood pressure, height, and weight. Pretty simple numeric values, but it's still not available to most of those clinical sites in our network. And so then on top of that, we have this challenge of seeing if any of those structured data elements that are specific to family planning are also available to them. So here are our basic demands. We have this huge, diverse network. There's a lot of local needs and a lot of different reporting structures. There's a variety of tracking and reporting systems already in use and that they have to talk to. We would like to understand clinical performance in a better way. There's also been a lot of improvements in actual electronic data exchange and capture, but it's still not quite as far along as maybe we would need it to be. And there's a lot of high individual costs to develop all of these local systems and then also to keep them going and keep the data important and relevant. So our particular use case, again, we've got 7 million patient encounters. We've got a lot of clinical sites. Not all of these sites are actually able to make decisions about their data systems, right? They may be at the whim of higher tiered folks in their organizations, so they don't actually maybe not get involved in the requirements design and analysis. And so they can't really help push forward the initiative that we're looking at in particular. So we have a lot of target data flows from this local clinical level and administrators. We would like to be able to capture data that just more or less comes off of the top of the visit that would normally be happening. We don't want to interfere with clinical workflow. We just want to get the data that we know that they're already entering because it's already just basically good care and follows good clinical guidelines. And we'd like to report that out, extract that, send it off, and use it for other initiatives, and then make it available back again to those users. So the basic technical solution that we settled on for the IHE family planning profile was something called RFD, or Retrieve Form for Data Capture, which is in the IT infrastructure. That's the base standard in there. So basically the local system, an EHR system, the form filler, that system sends a retrieve form request to someone who is managing the central directory of forms. And that initial form request can include, in our profile, we've clearly mapped out how you construct a CDA or CCD request so that we can pre-populate that data when it comes back in the form response and presents it to the user. Right, so the user doesn't have to enter in all the information that we're looking for. It's already been sent over the wire. And then the user gets a pause, more or less, a break, and they look at that form. It's displayed, hopefully, in what feels like a native environment to them. They didn't have to log out of their EHR system. They didn't have to go to some other system. It feels like it's already inside of that EHR system. They can check anything over. If that initial request was missing data, maybe that system doesn't actually capture a data element, for example, like pregnancy intention over the next year, then they can actually enter that information in because it was likely on a paper-based form or somewhere else entered into the medical record system as free text. Then they can submit that form, send it off the repository, and it becomes immediately available, hopefully, in a secure login dashboard analytics platform. So what is the value of that? Well, first of all, I'll go back and say, this is the one-off kind of scenario. What if you have 10,000 records that you need to submit? We're working on updates to the profile to make it possible for vendors to be able to submit a whole bunch of records all at once. But here's the real value. The current state is that there's multiple reporting requirements. There's a lot of jurisdictional variation. There's incomplete structured data. Vendors have varying and unique implementations. We talk with our vendor partners, and they didn't even quite realize that all of these sites were even one connected network, and they were hopefully trying to figure out who was at the source of all of these requirements. And the future state that we're looking for is basically better clarity, saying these are the data elements. This is how you can send it to us. We want to be really super clear. It's only about 33 data elements. It's very much overlapping with all the basic clinical care you'd already be ordering for the usual patient visit. And we hopefully that reduces your required code base for the vendors as well. You don't have to worry about all these jurisdictional variation across different entities and organizations and states and counties and provinces, and you get to focus on perhaps usability design and making sure that you're up to date on other issues. So this centralized forms management and clarity of the requirements makes it so that the local system can be agnostic, more or less, of some of these methods. You just have to be part of knowing the modern web services data exchange. And ultimately, the whole point of this is to make it easier to say, well, you know what, there's a new outbreak of an epidemic in the case of surveillance reporting, and you never know what kind of data elements public health is going to require, and this makes it a little bit easier to say, it makes it faster for vendors themselves to just respond and provide those data elements and make that available to the user, even if it's not already in their system. And again, the final goal is to really just to free the data, give it back to users in real time, and we also publish the ways in which we will be calculating some of these measures so that vendors could even do them internally into their own system. And all of these artifacts are made available to the public. They're vetted publicly because IHE is an open standards development organization, and it makes it a whole lot easier for our entire network and all of our vendor stakeholders to participate and to clarify and to make sure that we're all working